Aggressive periodontitis. It is a type of periodontal disease that is characterized by rapid loss of attachment and alveolar bone. According to the 1999 International Workshop for Classification of Periodontal Disease and Conditions, aggressive periodontitis has primary features as rapid rate of attachment loss and tooth supporting bone. It affects healthy individuals with no systemic disease or condition, and it has a family history of aggressive disease with a genetic component associated with development of aggressive periodontitis. The secondary features involve absence of large amounts of plaque and calculus but high amount of tissue destruction. There is a strong colonization of Aggregatibacter actinomycetum comitans, also called as AA, and P. gingivalis. There are immunological defects wherein there is hyperresponsiveness of macrophages and abnormalities of neutrophil function. The disease is also self-limiting. In some patients, there is significant amount of periodontal tissue loss at young age or at a short period. This is called as aggressive periodontitis. It is characterized by periodontal tissue loss which can occur on selected teeth or generalized manner. If it is present in selected teeth, it is called as localized periodontitis. If generalized, it is called as generalized periodontitis. Localized periodontitis normally affects the incisors and molars, and generalized periodontitis occurs at least in other 3 permanent teeth in addition to incisors and molars. So there are 3 types of periodontal disease according to the 1999 classification: chronic, aggressive, and periodontitis as a manifestation of systemic disease. Aggressive periodontitis differs from chronic periodontitis in that aggressive periodontitis has an onset of age of under 30 years. There is a rapid rate of disease progression. The composition of bacteria differs where there is presence of AA, there is alteration of host immune where there are abnormal phagocyte functions, and hyperresponsive macrophages with increased release of inflammatory markers like prostaglandins and interleukins. There is familial aggregation of disease where individuals are having a genetic components related to aggressive periodontitis. So aggressive periodontitis, which was previously classified as early onset periodontitis, has 2 types: localized and generalized. Localized aggressive periodontitis. It has a molar incisor pattern of involvement. It was called as juvenile periodontitis as it was seen around puberty. Defined by Bayer in 1971 as a disease of periodontium that occurs in healthy individuals with a rapid loss of alveolar bone, affecting more than 1 permanent tooth with less deposits but more destruction. So, it was called as localized juvenile periodontitis, and eventually it was termed in 1999 as localized aggressive periodontitis. The clinical characteristics of LAP are: it occurs around the age of puberty, it characteristically affects the first molars and the incisors, there is interproximal attachment loss in at least 2 permanent teeth, one of which is the first molar, and not more than 2 other permanent teeth. There is lack of clinical inflammation, the presence of deep periodontal pockets, and advanced bone loss. So the amount of plaque present on the teeth is inconsistent with the amount of periodontal destruction. The plaque layer is thin, it rarely mineralizes, and has high levels of AA and PG. Localized aggressive periodontitis is a rapidly progressing type of disease with a rate of bone loss which is 4 times greater than chronic periodontitis. There is distolabial migration of maxillary incisors and diastema formation. There is mobility of maxillary and mandibular incisors and molars, and the teeth are sensitive to touch and thermal. There is deep, dull, aching, radiating pain on mastication due to mobility of teeth and food impaction. There could be presence of abscess formation and regional lymph node enlargement. The possible reason for localization of this destructive disease is 1. Strong antibody response to infecting agents. Molar and incisor teeth are the first teeth to erupt, hence they are colonized by Aggregatibacter actinomycetum comitans. AA has the ability to breach the host defense by producing certain factors like PMN chemotactic inhibiting factor, endotoxins, collagenase, and leukotoxin. This allows AA to colonize in the periodontal pockets and cause destruction of the tissues. However, simulation of host defense produces certain opsonic antibodies and clears the bacteria, and also allows phagocytosis of the bacteria. This results in localization of the disease. Another reason is bacteria antagonist to AA. Bacteria other than AA can colonize to the periodontal sites and restrict the growth of AA. This leads to localization of infection and tissue destruction. Third reason is the inability to produce toxins by AA. Leukotoxin produced by AA has the ability to cause periodontal disease. Due to certain reasons, loss of leukotoxin producing activity by AA results in arrest of disease progression, and ultimately no further invasion of periodontal site results. Defect in cementum formation. Defect in cementum formation due to hyperplastic or aplastic cementum can restrict the localization of the regions. Coming to radiographic findings of localized aggressive periodontitis, there is vertical bone loss around the molars and incisors, which is a classic diagnostic sign of localized aggressive periodontitis. There is an arc-shaped loss of alveolar bone that extends from distal surface of second premolar to the medial surface of second molars. The bone defects are wider than that seen in chronic periodontitis. Localized aggressive periodontitis affects both males and females equally. It is seen around puberty and 20 years of age. Coming to generalized aggressive periodontitis, it affects individuals under 30 years of age, but may affect older individuals as well. There is a poor antibody response to pathogens, and the clinical characteristics are there is generalized interproximal attachment loss, which affects at least 3 teeth in addition to incisors and the first molars. The periodontal attachment loss occurs in episodes, that is, there are periods of advanced destruction and there are stages of quiescence that can last from weeks to months. In generalized aggressive periodontitis, the plaque is thin in layer, has high levels of AA and PG, and Tannerella forsythia. Also, like LAP, the amount of plaque on the teeth is inconsistent with the amount of periodontal destruction seen on the teeth. Gingival appearance in generalized aggressive periodontitis. In destructive stage, there is severe and acute inflammation that results in proliferating, ulcerated, and fiery red gingiva. It bleeds spontaneously with slight provocation, and the important feature here is suppuration present through the periodontal pockets. In periods of quiescence, the gingiva could be free of inflammation and appear pink. There is some degree of stippling which may be present. However, there are deep periodontal pockets present. Radiographic findings of generalized aggressive periodontitis. Radiograph may show severe bone loss around incisors, first molars, and 3 or more teeth, or there could be advanced bone loss around majority of the teeth. Generalized aggressive periodontitis is seen around the age of 14 to 17 years and affects male more commonly compared to the females. The yearly loss of attachment ranges from 0.1 to 1 millimeters. There are certain risk factors for development of aggressive periodontitis. These can be grouped into microbiological factors, immunological factors, genetic factors, and environmental factors. Under microbial factors, localized aggressive periodontitis may show presence of Aggregatibacter actinomycetum comitans in about 90% of the lesions. However, in localized and aggressive periodontitis, other bacteria may also be seen like Porphyromonas gingivalis, Tannerella forsythia, Prevotella intermedia, Campylobacter rectus, and Trichoderma denticola. Immunological factors involved in aggressive periodontitis are presence of human leukocyte antigen, which can be a marker for aggressive periodontitis. Presence of HLA-A9 and HLA-B15 is an indicator of aggressive periodontitis. Functional defects of PMNs and monocytes. Impaired chemotaxis of PMNs and inability to phagocyte or kill microorganisms can result in aggressive periodontitis. Hyperresponsiveness of monocytes due to production of prostaglandin E2 can result in increased connective tissue and bone loss. Poorly functioning monocytes with the defective receptor for human immunoglobulin G2 can result in development of aggressive periodontitis. Autoimmunity plays a major role in aggressive periodontitis. Antibodies are found against collagen, DNA, and immunoglobulin G. Genetic factors. All individuals are not equally susceptible to aggressive periodontitis. there is a familial pattern of alveolar bone loss. Due to presence of genetic predisposition, localized aggressive periodontitis can be seen in families. Genes play a major role in aggressive periodontitis. It could be autosomal dominant, and antibody response to AA is under genetic control. There can be presence of high antibody titer against immunoglobulin G2. Environmental factors like smoking can affect periodontal disease. The amount and duration is equally important. Smoking can lead to more teeth involvement and more attachment loss, ultimately resulting in generalized aggressive periodontitis. Treatment considerations for patients with aggressive periodontitis. They can be treated with anti-infective therapy, amoxicillin 500 mg 3 times a day for 3 days, and metronidazole 400 mg 3 times a day for 7 days. Patients allergic to penicillin can be given doxycycline 100 mg 2 times a day on first day and 100 mg 1 time for 21 days. In addition to anti-infective therapy, surgical therapy may be needed. It is indicated for localized aggressive periodontitis patients with pronounced loss of attachment and deep periodontal pockets, because these are the areas which are difficult to instrument. Vertical bone defects need treatment. This is followed by supporting periodontal therapy, where the patient who suffers with aggressive periodontitis has a virulent microbial burden due to presence of AA and PG. There is also alteration in host defense, which results in rapid loss of attachment. Thus, it is important to have a maintenance phase designed for the patient, with good oral hygiene maintenance and minimize the amount of plaque present. So the clinician role is to regularly assess the periodontal parameters every 3 months. Coming to oral rehabilitation and implant therapy in case of loss of teeth. Dental implants come out to be a very good source of replacement of teeth. They are predictable in functional and aesthetic replacement of lost tooth. However, there is risk of peri-implantitis due to history of periodontitis. So to summarize, aggressive periodontitis has rapid rate of attachment loss and tooth supporting bone. It affects healthy individuals with no systemic condition or disease, and there is a family history of aggressive disease with genetic component involved. Localized aggressive periodontitis has a molar incisor pattern of involvement, and there is arc-shaped radiolucency seen in radiographs. In generalized aggressive periodontitis, there is generalized interproximal attachment and bone loss, there is a poor antibody response, and there are periods of destruction and quiescence. Risk factors associated with aggressive periodontitis are microbiologic, immunologic, genetic, and environmental. Treatment strategy involves use of antibiotics, surgeries, implants, and supportive therapy. You can find the link to MCQs for this topic in the description of the video. Thank you for watching the video. We hope you liked it, and if you did, please subscribe to the channel and hit the notification bell for update on new videos. Thank you.